Hi everyone, welcome to the Wet Lab here at Lions World Vision Institute. I am really sorry that I cannot be here in person today. My flight has got cancelled. However, I'll try my best to be able to explain the basics of CAIRS keratoplasty to you as well as I can. These are my financial disclosures. And let's see why we call CAIRS as CAIRS keratoplasty. Let's take a look at the other forms of keratoplasty first that have been used in keratoconus. Penetrating keratoplasty is still done sometimes in keratoconus, and it can have a lot of disadvantages, including sight-threatening complications such as choroidal effusion or expulsive hemorrhage, infection, and so on. And also the other big problem, of course, is primary graft failure or rejection, which can lead to loss of the graft and decreased vision. In addition to that, other complications such as increased intraocular pressure, either because of the surgery per se or because of steroids that have to be applied long term just for graft clarity, are other problems. Postoperative suture-induced astigmatism, even in the perfect case, can be another complication. And of course, once a penetrating keratoplasty is done, it's an invasive and irreversible procedure. Let's take a look at DALC for keratoconus, and we know that here too you can have suture-related issues such as lipid keratopathy, suture loosening, corneal neovascularization along the sutures, and so on. And also, as long as the sutures are there, there's a much longer period of time taken for a return of stable visual acuity. In addition to that, sutures can also cause irregular astigmatism. The 360-degree cut through the cornea can lead also to surface related issues such as corneal denervation, dry eye, and in addition to that, just the fact that you have got an interface can lead on to interface haze, and sometimes even problems within the interface such as the neovascularization or as I mentioned earlier, lipid keratopathy. The biggest problem, of course, with DALC is that it has a steep learning curve and can even have the risk of perforation that can sometimes necessitate conversion to a penetrating keratoplasty. Now, what are the other things that can be used for the treatment of keratoconus? And one of the commonest things that were being used, of course, was the synthetic intrastromal corneal ring segments. These are, as the name implies, made of synthetic material, PMMA, which are implanted deep within the corneal stroma. And the reason they're kept deep is that synthetic PMMA really does not stay in a safe manner for long term within the cornea, and therefore you have to have sufficient amount of tissue above it to prevent anterior stromal melt. And this very problem, of course, implies that you have a loss of effect because they're implanted so deep, and also the fact that you have to implant them in the periphery to get effect. And all of these are disadvantages of synthetic ICRS. In addition to that, you can also have issues with existing techniques with reports of complications up to 30% using synthetic rings, some of which I already mentioned. And therefore, these are also not really ideal means to correct or to treat keratoconus. Other disadvantages of synthetic rings include the fact that you cannot use it in very thin corneas or very steep corneas, and therefore you've basically lost a large percentage of keratoconic patients who really need visual rehabilitation. You're not able to offer them anything because they're not advanced enough to do a DALC, but they're a little too far advanced to be able to do a synthetic segment safely. So as I said, synthetic segments such as Intacs have been known to be associated with stromal melt, especially in patients with poor biomechanics and eye rubbers, and sometimes even acute eye drops has been reported by posterior migration of synthetic segments. Now coming to corneal allogenic intrastromal ring segments, LWVI provides these as sterile CARES, and basically you can implant them much similar to the synthetic segments except that you're using allogenic segments. It was first described by me in 2015 as a new treatment for keratoconus, and since then it has become really popular around the world. And what, of course, is done is that you implant donor corneal tissue into a peripheral channel. And what this donor corneal tissue does is it flattens the cornea and leads to an improved corneal shape, a less irregularity of the cornea, and all of this results in better visual quality. And if you look at it, CARES is actually a form of micro-invasive intrastromal lamellar keratoplasty because you really are putting a bit of tissue into the cornea, and this results in all the desirable changes, and it can be done in an extremely micro-invasive manner. What are the benefits of CARES keratoplasty for the treatment of keratoconus? One is, of course, the big one that you can avoid complications of penetrating keratoplasty or DALC. And you can always use natural human corneal tissue, but this does not really require any special FDA approval for this. In addition to that, corneal tissue we know is very biocompatible, it biointegrates well, and we've got a long history of safe usage of corneal grafts. You can customize CARES for individual topography, and that's a huge advantage. In addition to that, another big advantage is that it is placed outside the visual axis, so the safety level is really high. You can combine it with corneal cross-linking, and other big advantages are that it is reversible and adjustable. It is also revisable, and it has got outstanding cosmesis. In terms of CARES keratoplasty outcomes, it has been reported to have great outcomes in multiple studies with reduction of K1, K2, K mean, K max, topographic astigmatism. Q value comes closer to normal asphericity, sphere, cylinder, and spherical equivalent all decrease, as also RMS, high rod aberrations, and vertical coma. All of these, of course, result in better uncorrected and best spectacle corrected visual acuity for the patient, as well as a better quality of vision. Now, if you've decided to go ahead and start CARES keratoplasty, how would you go about and select your patients? Well, some of the good patients that you can start off with are those who cannot tolerate their rigid gas permeable lenses or scleral lenses. They don't have a good fit or they're uncomfortable wearing it. And these are good candidates for CARES keratoplasty. Patients who desire better uncorrected visual acuity without contact lenses on, that's again another great indication. Now, though you can do it in early to advanced cases, some of the best cases that you can start out with would be from about 50 to 60 or 65 diopter Kmax. You can do this procedure in both progressive and non-progressive cases. You can also do it in very thin and extremely steep corneas, but I think the first cases that you do, as I said, the ideal cases would be between 55 to 65 diopters. A patient with a mild apical scar can still be considered for CARES keratoplasty, so that doesn't completely rule out CARES. What you can do is do a RGP contact lens trial, and if the patient's vision improves with that, the patient can be considered a candidate for CARES. Now, coming to CARES preparations, there are various options. You could prepare your CARES from fresh full thickness cornea using two donor punches to cut it sequentially, but I do not like this because this is not reliable and you can get a lot of variability in the width and the thickness if you cut this in this manner. I personally prefer to use my own Trifine, which is the Jacob CARES double-bladed Trifine. It is now available with Akriti in USA. In addition to that, you can cut CARES with the femtosecond laser intraoperatively, but you do require specific CARES software for this. Now, instead of preparing the tissue yourself, you can also get it prepared from the eye bank, either manually punched fresh or sterile, which has a shelf life. And as I said, optigraph CARES from Lions World Vision Institute here are cut with the femtosecond laser, so they are precisely cut and they're sterile with 2 years shelf life. Now, let's just take a quick look at surgical planning and procedural steps. Now, when you're starting out with your first case, an ideal case would be a decentered cone. So what you do is you draw an imaginary line across the pentacam or the map to divide the cornea into two regions. And if it is steeper inferiorly, that is where you're going to place the segment. And the segment length should cover the steep area. Now, how do you decide between one or two segments? If the cornea is flat in the opposite hemisphere, less than mid 40s, you put only one segment on the steeper side. However, if the cornea is steep on both sides, then what you do is you go ahead and put two segments. Now, what is a perfect first case? The perfect first case would be, as I said, a decentered cone to start out with. It would be nice to have a patient where the other eye has reasonably good vision. Again, a good case is where the corrected distance visual acuity is less than 6 by 12 or 6 by 18 in the eye with greater ectasia. A patient who's contact lens intolerant. And for your first case, obviously, you want to set expectations right. And the patient should not think that he's going to get as good vision as he will with contact lenses. A decentered cone, I already mentioned, is the best initial case. And remember to put a single segment over the steepest area. Again, how would you insert it into the patient's eye? What you do is you create a femtosecond laser dissected channel at approximately 50% of the corneal thickness, and you can implant a 550 into 1000 microns optigraft in a 1.5 millimeter tunnel at roughly 250 microns depth. Now, if you want to increase the flattening, what can you do? You can increase the width or the thickness of the tissue, or you can decrease the optic zone. You can go more shallow, though I personally don't advocate it because too shallow placement can result in overlying stromal melt. A narrow tunnel width can also be used, but again, do not make it too tight. I don't like CARES to sit extremely tight inside their channels. In fact, a comfortable fit is much better because CARES does not act by a pseudo limbus effect or a false limbus effect. It actually acts by volume augmentation. So you do not have to aim for extremely tight tunnels because that's again going to be increasing the risk for stromal melt. A younger patient will have more flattening than an older patient. And of course, if you want to decrease the amount of flattening that you get, then you do opposite of what we just said. So for the optigraph CAIRS, a tunnel that's about 0.5 millimeters wider than the CAIRS width would suffice well, and you would be able to get it in relatively easily. What are the cases that you want to avoid initially? Post-LASIK ectasia, very steep central K of more than 65 diopters, I would say, not 60, very thin central corneal thickness of less than 330 microns, and large central apical scars, which are going to cause a decrease in vision. So I do hope that this gives you a rough idea of how to start off with your initial CARES cases, and I'll be happy to help you get along with this. In case you have any doubts, please reach out to all the people at Lions World Vision Institute who are extremely helpful, and I'm also always available. Thank you so much.